I hereby open this academic ceremony in which Mauro Cavarra will defend his academic thesis entitled Trip the Pain Away, Psychedelic Therapies of Mental and Physical Pain. And we would like to start this ceremony by a presentation of the candidate about the summary of his studies and the conclusions of the thesis. The floor is yours.
Thank you. Dear Prorector, dear members of the committee, dear family, dear friends, thank you for being here. In the next 15 minutes, I will tell you a little bit about the research that we've conducted in this topic. The title of my thesis is Trip the Pain Away, Psychedelic Therapies for Physical and Mental Pain, and our main objective was to answer the following question. Do psychedelics have analgesic effects? And in order to answer this question, since if they do have psychedelic effects, these may be in the future be used to treat chronic pain. In order to answer to this question, I will walk you through a series of studies that we conducted using diverse methodologies. More specifically, a survey study with chronic pain patients who made personal use of psychedelics, a case study with a fibromyalgia patient who took part in a psychedelic-assisted psychotherapy program, and an experimental study with healthy volunteers aiming at testing the analgesic effects of small doses of LSD. Finally, I will speculate on potential future avenues for research and for clinical applications. But first, some information about chronic pain. Chronic pain affects 1 in 5 people, according to recent estimates, and bears a substantial societal and personal cost, as is one of the major causes of disability. Furthermore, many patients do not respond to conventional medication, and in some cases, when they do, they suffer from very severe side effects, as we were made painfully aware by the opioid crisis. Interestingly enough, psychedelics seem to act on some of the same receptor systems that are responsible for pain perception. But what are psychedelics? We are talking about a class of compounds that include LSD and psilocybin, which is the active ingredient of magic mushrooms. They produce marked change in consciousness, and they have shown that to produce beneficial effects in mental health conditions, as well as holding promise for the treatment of chronic pain. And now let's get to the studies. Our first study was a survey study aimed at answering the following question. How much relief do psychedelics produce compared to conventional medication? We asked this question along with many others in our battery to 170 patients who were suffering from chronic pain and who made personal use of psychedelics. And analyzing the data, we found out these results. As you can see in the graph, full doses of psychedelics led to greater relief compared to microdoses, that is, small doses of psychedelics. In some cases, microdoses produced greater relief compared to conventional medications, and in other cases, microdoses were able to produce the same or comparable amounts of relief compared to conventional medication. The patients that we studied were suffering from a variety of pain conditions, such as fibromyalgia, which is a condition that causes diffused pain in the body, especially in the joints and in the muscles, along some other more known chronic pain conditions, such as arthritis, migraine, and tension-type headaches. This study gave us a bird's-eye view on this phenomenon, but if we would zoom in, down to a single individual, we may find someone like Adam. Adam is the fictitious name for a chronic pain patient suffering from fibromyalgia who took part in a psychedelic-assisted psychotherapy program with the hopes that that could help with managing his symptoms and more generally at improving his general well-being. We wanted to know whether psychedelic-assisted psychotherapy can help a patient with fibromyalgia. To get into more details, Alan embarked in a psychedelic-assisted psychotherapy program in which he was involved in some preliminary sessions in order to prepare for the psychedelic sessions. Then he went to this 4.5-day retreat in which he was involved in 2 high-dose psilocybin group sessions. After that, we interviewed him 3 times and we administered some tests to understand what changes he went through as a consequence of the therapy, or I should say following the therapy. So let's have a look at the results that we observed. So first of all, let's talk about pain. Adam reported that the pain that he felt went down during the sessions and in some cases completely disappeared. He also reported in our 6 months later interview that the degree of pain was reduced, and along with these changes, some other interesting things happened for Alan. First of all, his suffering increased right after the psychedelic retreat. And when he was asked why, he said that during the psychedelic trip, psilocybin showed him all the changes that he needed to do in his life in order to improve his general well-being and his management of the symptoms. And these life changes definitely followed and had the desired effect. More specifically, Adam felt more capable of accepting the pain. He felt more aware both of his bodily needs and his emotional needs. He felt increased mood, decreased anxiety. He felt an improvement in avoidance behavior in connection to self, to others, and to his spiritual side. And to give you a closer view to Adam's experience, I've reported some quotes that come directly from the interviews. Adam says, "The experience changed my life on a fundamental level. It sped up healing and it led to real progress." And furthermore, he says, "I'm more able to just let the pain be, not judging it as a negative thing." Now, these words are especially relevant if we consider that chronic pain patients often experience a sense of powerlessness towards their pain. They perceive their pain as this unstoppable force against which there is nothing they can do, and that progressively eats up their daily life and prevents them to live a fulfilling life. But let's leave Adam now and let's go to the lab. The third study I would like to talk to you about is a randomized controlled trial in which we wanted to respond to this question. Can LSD microdosing increase pain tolerance in a healthy volunteer sample? Microdosing, psychedelic microdosing, is a practice in which people take small doses of psychedelics repeatedly across the week for several weeks. It is generally done to achieve some sort of benefit for one's, cognitive performance, memory, mood increase, etc. We will obviously look at the effects that this microdosing had on pain. In order to answer our research question, we administered to our participants either 15 micrograms of LSD, which is a pretty small dose, or a placebo, 4 times over 2 weeks, basically 2 times per week. And we involved them in a pain-evoking task. This task worked as follows. We asked the participant to submerge their hand into a bucket of icy cold water, and we asked them to keep that hand inside the bucket for as long as they could. The time that they were able to keep their hand underwater was our pain tolerance measure. Also, once the task was over, we asked them to respond to some questions about their subjective experience, so basically how painful, how unpleasant, and how stressful the experience was. If the task lasted 3 minutes, then we would interrupt the task anyway. So, the results were pretty underwhelming, because we found no difference between the experimental group and the control group. But by digging a little further into the data, we realized that almost half of our sample was pain-resistant, which means that even at baseline, so even before receiving any kind of treatment, either placebo or LSD, they were able to sustain the pain task to its maximum duration, 3 minutes. This has a very practical implication. In this case, even if LSD had an analgesic effect, we wouldn't be able to detect it. So we decided to repeat the same analysis by removing the part of the sample that was indeed pain-resistant. And in this case, we were able to detect some results. We saw, for example, that in terms of unpleasantness, our participants experienced a lower degree of unpleasantness if they were in the LSD group for the first microdose of LSD, not so much in the doses that were administered later. And a similar response pattern was found also for pain tolerance, which is the time that they were able to keep their hand in the cold water. This is the last study that we will discuss in this presentation. Let's now have a look at what the future holds for this field of research. So, if the analgesic effects of psychedelics will be confirmed, then we have several open questions for the future. First of all, a very foundational one: what doses should we use with these patients in order to achieve analgesic effects? For example, should we aim for a model in which we give patients a high dose of psychedelics, aiming at giving them an intense experience, hoping that this will then, that the analgesic effects will then carry over into their daily life? Or should we think more of a microdosing-like model in which we give small doses of psychedelics repeatedly across several weeks? This question is still open. Furthermore, with what dosing schedule should we treat these patients? How often should they receive the treatment? Also, there are reasons to believe that psychedelic treatment can improve its effectiveness when paired with psychotherapy. The study that puts the nail on the coffin on this issue has not been run. So the comparison between a psychedelic treatment that doesn't use psychotherapy with a psychedelic treatment that uses psychotherapy has not yet been done. But there are reasons to believe that this addition may be helpful. If it doesn't provide an additional value, if psychotherapy doesn't provide an additional value, then we would be completely into a medical model, which means that we would have to just figure out how much of the substance and how often and for how long should we give the substance for the treatment. But in case we see that psychotherapy may have an additive value, then there are several questions that we need to answer. For example, how directive should the therapist be? In other words, how strongly should the therapist orient the content of the session in order to optimize the clinical outcome for the patient? For example, should the therapist focus on techniques to reduce pain, on psychological techniques that can reduce pain, or more on the psychosocial aspects that we know are often around pain and we know have a mediating effect on pain intensity for patients? Now, most likely, we would have to strike a balance between these two areas, but still, how would that balance look like is still open for discussion. Finally, what about the setting? Are we envisioning a therapy in which the therapist and the patient are alone in a room and they carry on with the therapeutic process? Or are we envisioning a setting that is more similar to the ceremonial use of psychedelics, in which usually the experience is carried out in a group and it's carried out with a facilitation of a therapist or of a person connotated spiritually? Okay, we are currently testing one of these models in the lab. We are giving small doses of psilocybin to fibromyalgia patients in the hope to be able to contribute to their pain relief and help them achieve a fulfilling life. To conclude, psychedelics bring relief to individuals who are using them in naturalistic settings. Psychedelic-assisted psychotherapy may be a valuable addition to treat chronic pain, and LSD may have some analgesic effects at low doses. These results should be tested by replicating a design similar to what we used, but appropriately powered, which means with a sample big enough for us to be able to detect an effect. And with this, I conclude my presentation. I give the word back to the prorector, and I'll be happy to answer any question. Thank you.
Thank you very much for your presentation. We now continue to the opposition. You will have 5 opponents who will go into a discussion with you. And the opposition will be opened by Professor Blokland, who was the chair of your assessment committee. He is a chair in comparative neuroscience at this university. Professor Blokland.
Thank you much. Thank you very much, Pro-Rector. First of all, my congratulations to you and your team for finishing this just-in-time received thesis. Thank you very much. And describes interesting studies. And I'm happy to hear that you're happy to answer questions that we have for you.
It's rhetorical.
Oh, okay. Good to know. So let me first start with the proposition 6 that you have. Psychedelics are no panacea. So I don't really understand what you really mean with this proposition. Because, I mean, from your studies, it seems to strip the pain away. but do you refer to other diseases, or is it more restricted to pain? And so could you please explain this better to me?
Of course. So one big risk that is currently being run in the psychedelic science and more generally in the psychedelic community is framing these substances as some sort of miracle cure for anything. And if you go into the dark woods of the internet, you will find people that swear that psychedelics have helped cure anything from the most obscure and incurable disease to, unfortunately, the most diffused and prevalent diseases that we all would like to get rid of. So my proposition was a way to try and think about these substances as one of the tools that we can use to improve people, both on a clinical side, but also on a more self-developmental side. When you refer to the title of my thesis, I understand why you made that remark. I would like to say that this title represents more the wish for something to get out there in order for us to be able to better work, to better help these participants. And it's based on the fact that out there are several anecdotal reports of people who actually say that their pain went away or was strongly decreased after psychedelic experiences or after psychedelic treatments in more of a microdosing kind of way. I think that we are still far from concluding definitely that psychedelics can help with that, but it is a meme that it is outside, and that I think it's worth investigating to the bottom. Yeah.
So maybe in the future you foresee that it might be a panacea for pain at least.
That would be great. I hope that will come true.
Okay.
Most likely the treatment will be some integration of tools that are established and we know, plus new additions that hopefully can bring more value to their life.
Okay. Thank you to clear that up, yeah. I would like to take you to page 19, when I was reading, of course, an important part of the thesis, the aims of the dissertation, because that's where you lay out what you aim to do. And then I read there, you write there something about physical and mental pain, which I think is a bit, well, I think they are completely different, but you even state here that there are similar brain processes. That's striking me, because physical pain and mental pain seems to me very different definitions. So if you can allude to that a little bit more, or explain to me why that would be, which brain process would that be? And another question I have with respect to this one sentence is you refer to Schneidman. When I looked up this Schneidman reference, it's about suicide. So I didn't read the book. Sorry, I couldn't read it online, and it would probably be too much for me to read the whole book. But maybe you can explain why you refer to this suicide book in relation to pain.
Of course. Highly esteemed opponent, thank you for your kind words before and for the question. So, depressed patients or patients who have suicidal tendencies talk about their pain, their psychological suffering, I mean, in a very specific way. They tell you that their sadness, their depression, the fact that they feel let down by this life is so intense that sometimes they feel it as actual pain. So that is the general idea over which Schneidman built this construct. And I know that it can be controversial, because if we think about pain as commonly intended, it's something that comes out of an organic damage, and it seems so far away from something that can be generated actually by emotional state or by a clinical condition. But if we stick to what the patients say, that is actually pain. And we know that the suffering that comes from quote-unquote just depression and the suffering that comes from depression plus suicidality, it's very different, and it's described very differently. That is why during the first, and I would say, during the 90s, this kind of construct was put forth in the literature as a tool to predict suicidal risk. We know that people who have high degree of mental pain tend to engage in suicidal behavior more often, and we know that one of the predictors that reassures us in terms of the fact that that risk is going down is the mental pain going down. So these are the historical root of the construct. Now, I am no neuroscientist, so my understanding of the neurological basis for this, of the brain basis for this, is only limited. But what I can say is that there is literature out there that shows that people suffering from physical chronic pain and people who have high degrees of mental pain tend to share some systems. I would be happy to talk about this more with you once I deepen my knowledge. But as you may know, my background is mostly on psychotherapy and less on neuroscience. So I wouldn't want to say anything incorrect.
Yeah. Okay, well. We will have an interesting discussion at a later stage then. Yeah. Maybe I then would like to go to chapter 3, where you have this study with the healthy volunteers. And some things that strike me. First thing is that of course, you select participants that would like to participate in such a study with a psychedelic. And that could already lead to a bias in the selection. Because I can imagine that people who are not so much into psychedelics, they don't, and people who are in psychedelics, especially our students population that we have, seems to be that they are quite interested in the psychedelic research field, so that they may be more sensitive to and more prone to show any kind of effect. So that would be a bias. Do you agree with me, or do you think, well, it wouldn't be such a great effect in my study? Or
I completely agree with you. It is a bias that is inherent to survey studies, in which people are free to participate in the study or not. And so their attitudes towards psychedelics and their history of use may be a factor in their choice of participating or not. So I want to make clear that this study wasn't run in order to, again, put the nail on the coffin on this issue and demonstrate that psychedelics have an analgesic effect, but it's more of a preparatory work that will allow us to understand whether, first of all, whether this phenomenon exists out there, and maybe and see if there are grounds to then move the research to a more experimental setting, which is what we are actually doing now with a placebo-controlled study on psilocybin for fibromyalgia. At the same time, I think that being receptive to the messages that come from the community could be interesting, because in the past it has already happened that practices that weren't yet tested but were already diffused outside in the general population informed then clinical practice and research and led us to well, the first example that comes to mind is the studies that show that psychedelics actually have a pretty interesting effect on conditions such as treatment-resistant depression. Much of the pressure, much of the interest that supported then the realization of this experimental studies also come from reports from the population. Yeah.
It's another twist to my question, but I can understand the point of it. Yeah. But then, so if you, and what I read on one of the pages, so it's that you try to control for the expectation of the study, but then you ask for the mood. You give a mood questionnaire to maybe control for the expectation. So I don't understand why you would measure mood. Can you explain that to me?
Sure. It's two different constructs. So the expectation part obviously is looking at phenomenon related to the placebo effect and to expectation effect. There is an idea out there that the effectiveness of psychedelics in several areas may be empowered by the fact that people expect to have that kind of effect. While the mood variable is we administered as a separate question, and we included it to make justice to all that literature that shows that patients who take, for example, who suffer from chronic pain and take antidepressants, they report increases in mood, and that tends to correlate with the intensity of pain they perceive. In other words, mood, the level of mood seems to have an effect on the perception of pain. Another example of this is the studies that show that people who engage in psychotherapy and improve mood variables tend to have improved pain scores.
But then I would ask, did the correlation between mood scores and pain perception?
Yes, we actually did more than that. We tried to see if we could predict if mood had a role in predicting the effects on pain, and we found that it was independent from that.
Independent?
Yeah.
Okay. Okay, then I will leave my questions here and pass the word back to the prorector.
Thank you very much. Then the opposition will be continued by Professor Formica, professor in dynamic psychology from the University of Messina in Italy. Professor Formica.
Yes. Congratulations, Mauro. Found Mauro test's work very original and interesting because it opens up interesting perspective for the treatment of pain, for which my opinion is absolutely positive. General, one question, what are the main contraindications of psychedelic therapy? For example, some scientific research has found that some patients who participated in the study reported at last one side effect such headache, nausea, fatigue, insomnia. Other patients have even experienced serious side effects such as suicidal tendencies, such as self-harm. Have you verified this side effects from your studies?
Yes, so let me answer to the first part of your question. So generally speaking, psychedelics are considered safe if administered to an appropriately screened group of patients or of healthy volunteers, which means that usually the exclusion criteria for those studies report the exclusion of people suffering from psychotic disorders or who have first-degree family members who suffer from these kinds of conditions, and people with bipolar disorders. Usually these are the strongest psychiatric exclusion criteria that are used. Most of the adverse effects that you mentioned when psychedelics are taken, again, by people that are appropriately screened, so the nausea, the headaches, etc., are usually transient and go back to normality after a couple of days, a couple of weeks at most. When it comes to more severe potential adverse events, there are rare cases in which these were reported, and this is one of the reasons why some authors in the literature suggest that the psychedelic experience itself should be contained within a psychotherapeutic framework that includes both a preparation phase in which we literally prepare for this intense experience that will follow. We inform the participants of the effects that they could expect, and we help them hone in on their therapeutic intention on the one side. And after the session, it is very important that a phase of aftercare follows that is usually referred to as integration, in which people not only can discuss the contents of their psychedelic experiences in order to process them and possibly integrate them in their own life, but also as a safety measure. Because if a patient starts suffering as a consequence of what was brought up by the intense experience, then it would be nice for them to be within the attention of a clinical team that could actually take care of those. But I would like to stress that these severe adverse events are pretty rarely reported in the population. We should still pay attention to that and make sure that these needs are met. And thank you for your question, highly esteemed opponent.
Thank you.
Thank you very much for your question, Professor Formica. We now move to the next opponent, and that is Professor Kramers, and he is a professor in medication safety at Radboud University. Professor Kramers.
Thank you very much for for the opportunity to ask questions, dear candidate. This is, of course, wonderful work with hallucinating subjects, psychedelics and pain. I read it with great interest. I understand you are from Messina, and I found myself wondering how much of a psychedelic one must have taken to change beautiful and sunny Messina for cold and windy Netherlands, although I found out a lot of rain came down lately in Messina, but we can discuss that later. First of all, I want to go to your chapter 3. I think it's a very, very interesting study. And my first question is, were the researchers blinded when they did the studies? Just yes or no?
Yes, the study is blind. Highly esteemed opponent, thank you for your kind words. And for the question, yes, the study is blinded.
Also for the researchers. I only found the subjects were blinded, but maybe I didn't read it properly. Then the second question is, then you found out, as you already showed, that some of these patients has a very high pain tolerance, and you decided to exclude them. But how did you come to the definition? Because you said the people at baseline, but also at 3 of the 4 sessions later on. Did you do that before you made the study, or did you do it afterwards, after you found the results?
We did it after. It was a post-hoc decision and an exploratory analysis.
I understand that. Now, I looked at you base your study on the study of your supervisor, Professor Ramekers. He did a similar study on several amounts of LSD, and then he didn't find this extreme high number of pain tolerance in his healthy volunteers. Did you discuss it with him? Did you understand that?
Discussed it at length. Also because the lab has a lot of experience with administering that same test, the cold pressor test. Recently, for example, the lab was involved in testing the analgesic effect of other substances, let's say. So we were literally baffled by that. We went through all our procedures to figure out if there could be an experimental error there, but we didn't find any strong evidence for that. And so the only thing we could do was graciously accept this distribution, accept also that maybe something could have slipped along the way. We really don't know about that, and hoping that this result could be, that this design can be replicated in the future to clarify.
Okay, things happen. I know this is science, so but I didn't understand it either. Now, if you go to your page 100, that's chapter 3, figure 2, you have a nice, you show the results of the whole sample and the subsample. The whole sample has, of course, higher pain tolerance than the subsample, but what I was wondering about that you didn't find more variability in this sample, whereas you add up like half of the patients who go up to 180 seconds. So you understand that there should be more variability in your data. I would expect if you take these high pain patients out of it, or do I make a mistake? Because they are higher. I see it's about 120 compared to 60, so that makes sense. You put together 180 patients in it. Nevertheless, you have similar variability, or is that just also a fact?
I'm not sure I got the question. Could you please repeat it?
Well, if you look at page 180 in your page, you will find that's page 100. It's chapter 3, figure 2. Then you look at the whole sample, and you will find that the pain tolerance is about 100 seconds in the whole sample. But maybe I see that somewhat more variability. Maybe I have to skip that and go to another data here, because as you showed, when you showed your data before starting this discussion, you showed that at dose 1 in the subsample, you find a nice result that after LSD, the pain tolerance is more and the painfulness is less, so that's good. Do you think the pain tolerance data you show at day 1 is a significant clinical relevant difference or not?
So it is hard to conclude about the clinical relevance because the study was conducted with healthy volunteers. It could have some significance if we think about that most chronic pain patients also suffer from hyperalgesia, which is that phenomenon for which stimuli that shouldn't produce pain then actually end up producing it for these patients. But I understand that this is a long shot because it would be nice to be able to repeat the same design with the clinical population, which is what we're
I understand. Because at follow-up, you see the other way around. So now you see at follow-up that LSD patients are less tolerant compared to placebo. So do you think that that is really a true finding, that later on they are more sensitive to pain?
If we take this data face value, we could make this remark. And there may be also some mechanisms that may potentially justify these findings. For example, the fact that this may constitute a rebound effect. But to be honest, given the small sample size and the obvious limitation that the study has, it is hard to distinguish this from an incidental finding.
I understand it very clear. Because you would expect at long term, LSD would still have effects. That we have seen this in bromo, LSD. And also, you gave your dose every day, didn't you? And then at day 4, you don't see any effect anymore. I would expect this because LSD gives tolerance if you give it every day. So why did you give the dose every day, 4 days at a row? You get a very quick tolerance.
We did it every day. We did it twice a week for 2 weeks, on Tuesday and Thursday.
Okay, that's good. So okay, I'm sorry. So I didn't read that. So that's okay. Okay. Then maybe one small thing. Did you look at men-women differences in your studies? Because there are data that women are more sensitive to pain. I wouldn't expect that myself, but that I know these data are there. Did you look at differences between men and women?
No, we didn't. Given the small sample size, we didn't think that would have been
you could do the
conclusive. Yeah.
Okay. Then I want to go to the dose. You choose 15 micrograms because in this earlier study I mentioned 20 micrograms had some effects and 10 had not. But did you take into account that there is considerable variation in metabolism between subjects based on sex, on build, but also CYP enzymes? I know that LSD is metabolized by CYP2D6 and there's quite some variation between subjects. Maybe you just didn't find any result because half of your patients is the level of LSD is far too low, and then you did look at levels of LSD. Did you do some post hoc analysis whether you could see some dose effect relationship in your study?
No, we didn't run this analysis on pain, so I'm afraid I can't respond to that.
Could you give any comment on my ideas about CYP enzymes, or are you not into this in this area?
Sorry, your question on? Please.
Well, this variability in metabolism, which you would expect, do you think there might be some influence on results?
Yes, it could definitely be. And at the moment, so the literature out there is basically using 2 methods. Either we standardize the dose to a specific dose and we test it along participants, while another avenue to test these effects would be to calibrate the dose based on body weight, for example. Yeah, that could be an interesting avenue, definitely.
I think that might be interesting. I want to pose one more small question. If I can't see the rector, so if I'm not, you have to stop me.
Yes, please. Small question is okay.
Okay. Well, as you already said by another opponent, that the lifetime use of LSD is quite high in your subsample, and then they were not allowed to use LSD for 3 months. How do you know they actually did not use the LSD the last 3 months? They will have said it to you, okay? You just have to believe them. I don't think there's another way to do it, okay? So do you think that if... Sorry?
So we asked them not to do that. We run some tests right before the test day, but we, of course, cannot be 100% sure.
Yeah. Do you think that taking LSD in the past could change the effect? Because we think there's some neuroplastic effect of LSD, and you could envision that if you already have it, you will not have any benefit of LSD. And the question is, do you think that's the results you find in your healthy volunteers will be similar to patients who usually will not have taken LSD?
Well, if we assume that people use psychedelics before coming to the lab and engaging in the pain task, then we would probably see a lower effect because of potential tolerance building phenomena. In terms of the generalizability of the results, I wish I had this question asked like in 6 months, because we will have that data at some point when we will test, when we will finish our psilocybin study. What I can say is that I hope that that will be the case, because there are, even though the chronic pain mechanisms and the acute pain mechanisms are different, they share some of their basic systems. But I'm really not ready to comment at this point. I hope so for the patients. Yeah.
Okay. Well, I think I consumed far too much.
I enjoy your interesting discussion, but thank you very much. We go to the next opponent, and that is Professor Peters. And Professor Peters is Professor of Experimental Health Psychology at our own university.
Dear candidate, I first want to start by complimenting you with this quite bulky book. And also your team. I'm a pain researcher myself, and I know it's very hard to treat chronic pain patients. Once the pain has become chronic, we don't have that much of options. And so any attempt to increase on that and have additional options is very much welcome. So I started reading your dissertation with high hopes, high expectations, tripped the pain away. So okay, now we found it. But unfortunately, I was somewhat disappointed, and not so much by your work, but more that the final answer was not there. I mean, if you look at the evidence, it's in fact not that large that we can trip away the pain. And that's what you said. It was more a hope than that it's that's actual. But I'm really happy, and you also alluded to that already, that you are now doing an RCT with fibromyalgia patients with psilocybin, and to really see whether it can have an effect on chronic pain. But I was somewhat surprised about the dosage you are using. I don't know nothing about it, but I just asked ChatGPT, and ChatGPT told me that the dose you are using is more on the side of the microdoses. The high end, the 10 milligrams at least, are high end of the microdose, but still a microdosing. And usually for most trials they use 25 milligrams or something. So yeah, you're on the low side. So I was wondering, why would you expect with this microdose that it would have an effect? Because I really searched in all of your references, but I couldn't find any reference showing an effect on longer-term outcomes on chronic pain. If anything, there's something on acute pain. Not so much, your own studies, some indication, and from your supervisor. But only after 1 dose and not after 4. So why would you expect a longer-lasting effect?
Highly esteemed opponent, thank you for your kind words and your question. So I would start by saying that both avenues of research would be interesting. On the one hand, testing whether a microdosing schedule can reduce pain, and on the other hand, to see if full doses, just as in the case of Adam, will lead to a longer-lasting pain effect. For the specific study, we chose to work with smaller dose because there is the possibility that these doses are, if the analgesic effects are confirmed, that they are more compatible with an everyday life. In other words, some people may not find it easy to integrate a mystical experience regularly in their life, or they may not even be interested in doing that. Like maybe they don't need to go into this existential quest if they just want to treat their pain. So we thought that it would be, ideally, it would be nice if we could find a substance that would have minimal effect on consciousness, but still retain an analgesic effect. So that was the rationale that was behind the choice about the dose. Mm-hmm. I agree with you. There is not much in terms of enduring effect of psychedelics in the literature. And in our study, we will modestly test this with a follow-up period after the last dose is administered. It's just a 1-week follow-up period. And we hope that thanks to our study, but also the further development of the literature, we will get a response to this question.
Of course, it would be perfect if you could find something. But your expectations based on the literature should maybe a bit moderate, or do you really expect? Is it a one-time dose, or what kind of regimen are you using? Are they taking it for a longer period of time, and how long will you be measuring after treatment?
We are using a within-participant design in which all participants take 3 treatments, either 5 milligrams of psilocybin, 10 milligrams, or a placebo. Right. And we are interested to see if these different doses get 2 different results. Another potential approach to designing another study would be to test a microdosing schedule, similarly to what we did with the LSD study.
Oh, so now they're only getting 1 dose, and then they turn to the other...
They get 2 doses and the placebo.
Yeah, but one time.
Yes. So just to make it clear, we enroll the patients for 3 test days. Yeah. Each test day is far from the other by about 1 week. So they take the first dose, then we wait 1 week, then we bring them back to the lab for the other dose, and then for the third dose.
Yeah, I understand. So you're actually looking at the short-term effect and not so much on the... I think that's actually, I mean, I know it's very difficult, but that's, I think, actually what would be needed, to also look at longer-term effects. Because I found in all your references, I found one study with the migraine patients, I think it was van Schindler, and they also used microdosing, but there also was a follow-up of 2 weeks, and we don't know what happens afterwards. So that's really what we would need to know. So maybe in the future we can turn to that.
But at the same time, before thinking about the enduring doses, maybe we should make sure that an analgesic effect is there before planning a longer-term study.
Yeah, that's right. That's right. So that would be the first step for follow-up studies. Yeah. Mm-hmm. I was also interested in. I have other questions. Well, but I turn to this one. The serotonergic descending mechanisms, the potential, you point to that could be one of the mechanisms by which psychedelics act. In fact, I'm interested very much myself in these descending inhibitory and facilitatory effects, and also trying to see, can we use some manipulation to strengthen the inhibitory effects, or inhibit the facilitatory effects. And then I'm looking at more cognitive and behavioral measures or interventions to accomplish this. Would you think that psychedelics, that would be, if we would do a study together?
Oh, let's do it, of course. Yeah. Of course.
And how would you do it? Would you look more on the inhibitory side, the facilitatory side?
Well, first of all, I will ask for a suggestion to an expert on this, like you, for example.
Okay, we can talk about that.
Yeah, and I would. This is because my expertise falls mostly on the psychotherapy of chronic pain. So I would really listen to an expert on how to make sure that we can disentangle the effects that you mentioned.
And then, okay, but you're the expert on the psychedelics. So would you then go for the microdosing or for the full dose? What would you expect that would be most efficient?
It's a tough question because they are both very interesting. On the one hand, what I just said stands, but if we just go a little bit... it would be nice to have a treatment in which I give you something once and that carries over, as some patients are reporting. Problem is that we don't have any data on that, so I find it hard to decide what study would be better. There are some advantages in running microdosing study, or I must say small doses study, because people don't usually go through very intense experience, and so the containment around the patient can be more easily managed in the lab. So I think they both should be done. And probably the decision will fall then on issues related to resources and to the kind of patients we are able to access.
Okay, let's talk about that further in the future. It seems
Let's
interesting.
do it. That's really nice of you. Yeah, definitely. It's great.
I think I have time for a very small question still. Because you also describe quite a lot in your dissertation about this PAP, the psychedelic-assisted psychotherapy. There's a lot going on there. I mean, you have psychotherapy, sometimes it's cognitive behavioral therapy, and at one time there is this session with the psychedelics. Sometimes the focus is more on the psychedelics, sometimes it's more on the psychotherapy. But how can you disentangle these two effects? And you already said there is no study having psychedelics without the psychotherapy. But I was actually wondering, is there a comparison study that you have the psychotherapy without the psychedelic? I mean, then you can only see, does it add something?
So to be honest, that is my dream study. And I've been talking about for a while, like doing a factorial design in which we can actually test that. That would be nice. Because on the one hand, we have psychedelic researchers that swear by the set and setting model, saying that the treatment is not in the pharmacological effect, but it's more in the environmental and in the personal, in the internal variables. So, for example, the state of mind with which the patient approaches the experience. I would really love to run that study and see, and finally, I mean, still be informed by the theories that are out there, but also figure out if we are doing something superfluous or if we really need that level of containment for patients.
Yeah, so the psychotherapy could be superfluous, but also the psychedelic.
Definitely. Yeah, it would be nice to both have a placebo psychotherapy and a placebo psychedelic, and then put them in a factorial design and
lots of things to do in the future.
So
Thank
many.
you.
Yes.
I give back the word.
Thank you, and I would love to join this discussion, but not for now. So thank you, Professor Peters. We move to your final opponent, and that is Dr. van Velzen, who is an associate professor at Leiden University Medical Center. Dr. van Velzen.
Thank you very much, Madam Rector. Dear candidates, it is also my pleasure to join in your opposition. I would like to start off with congratulating you on this very interesting thesis with a collection of work that I have learned a lot from. We are currently collaborating on this psilocybin trial in fibromyalgia patients that was discussed by the previous opponents, and I think they paved the perfect way for me to give some questions to you. Happy to think along with you on what actually your body of work currently means and how to move forward. So, reading your thesis, I was intrigued by the fact that you try to combine the more biological and the more psychological components of such complex disease as chronic pain. And it kind of reminded me on a different drug, which is cannabis or cannabinoids, where we also see that there are patient reports that are highly positive and groups of patients that are highly satisfied with the use of cannabis or cannabinoid-based medicine for their symptoms, whereas scientific studies or clinical trials actually repeatedly have difficulties or actually fail to demonstrate clinically significant effects. So I was wondering, in your thesis, you described that psychedelics could work for pain, for psychological effects. They could be anti-inflammatory or even neuroplastic. So if you had to place a bet or put your money on some of those mechanisms of actions, could you choose or prioritize at least maybe some of these aspects? How do you think psychedelics work? Do they work on the biological, more somatic substrate of pain? Or do they primarily act on the maybe more psychological or neuroplastic phenomenon?
It's hard to say where I would put my money, but I can talk a little bit about how I got here, and I think that's informative concerning that, because before dealing with psychedelics, I was very interested in how psychological interventions could improve pain, and that's why I started working with hypnosis, which is another altered state of consciousness that has some support in the literature as a tool to reduce pain. And that gave me a unique perspective, I think, because, of course, the biological mechanisms and the psychological mechanisms are completely integrated, and we cannot really draw a strong line what I could see was that by changing the attitudes that patients have towards pain and by teaching them ways that allow them to focus their attention on the pain and quote unquote manipulate it, you can already, in most cases, you can already bring relief to patients. So if you allow me to twist your question a little more, I would say that I am sure that psychedelics can enhance these suggestive effects. And it would be nice to see if by using psychological techniques that are already that have already been shown to have an effect, plus psychedelics, we can improve that kind of outcome even more. This is not so. My money, I'm not putting my money here because I think it's the most important thing. Maybe it is what I would like, the question that I would like to answer. How far along can we push the psychological levers to lead to pain reduction?
Okay, great. So I interpret your answer as that you foresee a role of psychedelics in the psychedelic-assisted psychotherapy part of treating chronic pain, whereas I totally agree with you that these two substrates of pain go hand in hand, of course. So if we talk about psychedelics, we of course talk about psychedelic effects. So you have discussed already in the previous couple of minutes, but also in your thesis, that actually microdosing might be an option. Can you elaborate a little bit on the actual conscious awareness of people using psychedelics and the possible contribution to a therapeutic effect, whether this would be a psychological effect or maybe a direct biological effect? I think it's necessary.
Yeah, esteemed opponent, thank you for your question. So, so let's start from the more psychological ones. There were already attempts back in the 60s to see if, so outside of the chronic pain sphere, but more on the psychedelic therapy sphere, there were already attempts to test whether psychotherapy could be enhanced by taking small doses of psychedelics, so by doing small doses plus psychotherapy. And if you read the papers at the time, the description that they gave was like using psychedelics in order to favor the emergence of contents from the unconscious, or to be more able to tackle difficult emotional contents. So in terms of microdosing and in conjunction with a psychotherapeutic intervention, that could be something that helps. In other words, psychedelics may increase the sensitivity to certain therapeutic maneuvers that are known to work. And that was called back in the day the psycholytic model, in which I, how can I say this, I dilute the conscious awareness of patients. But we cannot rule out the possibility that the neuroplastic effects already work at low doses. Actually, there is data out there that show that is actually the case. We see increased levels of BDNF in the blood even when people take small doses of psychedelics. So that could also be a mechanism that may support a reduction in pain. If we add to that the anti-inflammatory effects that we are currently testing in the lab, maybe we may see that all these mechanisms together may bring more relief to our chronic pain patients.
Okay, so when we talk about... so it kind of gets to my next question, which is actually great, because when we talk about pharmacological interventions, we usually talk about C50s, right, which are concentrations at which we meet a certain effect. And of course, I would say for psychedelics, the wanted effect is pain relief. And the unwanted effect are any side effects that a patient or a user might suffer from. And I know that with other types of pharmacological interventions that have the psychedelic effects like cannabis, but also ketamine, these finding actually the balance between wanted and unwanted effects can be truly difficult in finding good therapeutic dose regimens. So if you think about what you know about psychedelics right now, do you foresee a place where, or a role for psychedelics where actually the wanted effects overtake the unwanted effects, given the fact that most chronic pain patients are a little bit maybe hesitant to experiencing those psychotypical effects you just mentioned, especially in a chronic setting? So do you think we can find a dose where actually there is analgesia, there's pain relief, but the side effects are still manageable?
So the only data on which I can rely to answer this question are, not the only, but most of them come from user reports that say that they were able to find this balance. But it is tricky because we know that psychedelics also have effects on mood, and that can have cascading effects on beliefs and on cognitive processes. So there is a possibility that we shouldn't be looking for purely at a dose that removes the pain without any conscious effect. Probably we should be looking for a dose that ultimately makes the patient feel better and make them more able to get on with their lives in a fulfilling way.
You may finish your answer if you want to, or?
No, I finished. The only thing is that, so maybe the last thing that I can say is that the focus should be on how fulfilled the patients are compared to how much pain they feel.
Thanks.
Thank you.
Thank you very much. Mauro Cavarra, the time appointed to defend your thesis has passed now. The degree committee will now withdraw to discuss the quality of your defense and your thesis, and we would like to ask you to wait here for our return and our conclusion.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Your mind, years can't fly by now, don't waste all your time, cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My east side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Mauro Cavarra, the degree committee here present has assessed the quality of your thesis and of your defense. And in view of their positive verdict and taken into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. And your supervisor, Professor Jan Ramakers, is entitled to confer upon you the doctoral degree according to university customs. Professor Ramakers.
Do you promise to work in accordance with the principle of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law, and in conformity with the decision of the committee here present, I hereby confer upon you, Mauro Cavarra, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Thank you.
Here you go.
So, Mauro, here we are. Who would have thought this 3 years ago, when you first contacted Dr. Kim Kuipers, because all the way from Sicily, you were interested to pursue some work in psychedelics. And given that this, even to date, is quite difficult in Italy, you were looking for positions abroad and contacted us. And Kim was immediately impressed and invited me and others to speak to you over Zoom about possibilities to collaborate. And there were a couple of qualities that impressed us immediately, I think, during these Zoom meetings. One was that it was clear that you were highly motivated and dedicated to work with psychedelics in the treatment of pain. The other quality was that you have this warm, soothing voice that tricked us into liking you and loving you immediately. So we were not surprised that you actually were working as a hypnotherapist. You were born with a voice to actually do that particular job. And then third, and that shows also your organizational talent, I guess, is you already had a network available in the sense that you contacted the University of Messina, where you lived and worked, whether they would be interested to set up a collaboration with Maastricht. I think these are the three ingredients that we liked a lot, and that we sort of decided upon, okay, let's go and continue with that. And of course, me, having a long history in cannabis research, I really, really liked the fact that I could supervise a joint PhD program. So, but your topic is psychedelics, and I was wondering, right, because now you have been promoted in Maastricht and in Messina, so the question really came to my mind, are you now the first PhD ever that promoted on psychedelics in Italy? I don't know the answer to this question, but it might be, and I think it's definitely the first in this particular century, but you're not the first researcher on this topic. And it's kind of a coincidence, actually, that the first, as far as I know, research that was done on psychedelics and pain actually comes from Italy, from Florence. And there is this Professor Secoteri, who published on this topic, I think, the treatment of migraine with LSD already back in 1963. And in 1977, he actually had a similar study where he showed beneficial effects of high doses of LSD on phantom limb pain. So some way or another, I think, after that, I don't think anything happened in Italy in this particular respect. And so you're sort of taking up this tradition and continuing that and taking the legacy a bit further, I hope. So congratulations with that. I think that's a very nice position to be at. And then in terms of the work, when you came over, that wasn't easy at all, right? Because one of the constraints was that everything should be done within 3 years. And not everything went smooth, like always, but you had a difficult task of handling different types of studies. You presented them, you had the NS1 study where you had like structured interviews, which is not easy to do and to analyze. You had the survey that you did online, and you had the experimental study, which also takes a lot of skills and qualities. And while doing so, you learned a lot on the spot, I think. And so within these 3 years, you acquired a lot of qualities like data management, data collection, the logistics, the statistics. We had a lot of statistics, particularly on that experimental study that we were interested in. And the fact that you developed your skills was also recognized outside of the laboratory, because while being with us, you got more and more invitations to present about your work, nationally but also internationally, and which is a good sign that people outside in the world actually recognize your qualities. Then, and while doing so, you sort of never lost your Italian charms and cool thing, which is amazing. But then again, you're an Italian, but you're not a prototype Italian, I would say. You know, some of your qualities are maybe typical, and some are less typical. And I was instructed not to talk about your romantic affair, so I will only talk about the atypical qualities of you as an Italian. And so, but that's maybe because of how I view Italians might be wrong, but usually I think of them as being very busy. But you are not. You're always cool and relaxed. And usually when you talk to Italian people, they speak at a very high pace. You don't. You have a very low bass and a very dark voice. You know, that's why you're a hypnotherapist. And often I get into arguments with Italians, and they get agitated. And you never do, right? You're always friendly, whatever the circumstance actually is. I think that characterizes you actually quite very well. And then other aspects that may be more typically Italian is that you like food, particularly Italian food. And I think of that sometimes when I see you at lunch. And I mean, we have Dutch people that take their lunches to work. I'm looking at Arjan Blokland, who does it every day. And I imagine that you take 2 slices of bread, and you put some cheese in between, you press on it and put it in your box. And then you take it to work, and then you have it sweating in your box for about 4 or 5 hours, and then it's fine. But I never see you do that, right? Because if you take your lunch, you want to have it fresh. Right? You bring your bread to work, you bring your ham to work, and then you build up your sandwich slowly. Right? With the first slice, you look at it, you talk a little bit to it, then you have another slice of ham on top of that, and you shake it. And then there's this leaf of lettuce to top it off, and another slice of sandwich. And you take your time when you're building that sandwich. I think usually like, I don't know, 4 minutes, 5 minutes. And you don't slice it, right? You keep it like it is. You don't slice it. You just eat it as it is. And because that's the way it is tasty and it's fresh. So I think you like freshness. I think you demonstrate that also by the fact that your thesis only arrived yesterday, so it's actually completely fresh. You can still smell it actually coming from the printers. I think that somehow that is connected. And yeah, so that sort of is who you are, I guess. And I'm also glad that we were talking about the past, but there is a future as well, right? One thing about was actually is Mauro had his birthday not so long ago, I think like a week or 2 weeks ago. So Mauro officially entered the Middle Ages, I think. But there are no medieval times ahead, Mauro, because you were very successful together with Dr. Kim Kuipers to obtain a grant from the tiny blue dot, which secures your stay with us for another 3 years. And we are very happy that we had you with us, and we are very happy that you stay with us for such a long time again. So I congratulate you with the work that you've done, the thesis, for being with us. I also congratulate your family sitting here in the first row, and all of your friends who may be listening online. And thank you very much, and I hope to see much of you in the future. Thank you.
Yeah, thanks a lot. Thank you.
Dottore Cavarra, tanti complimenti e congratulazioni per questo risultato.
Perfetto.
In other words, Dr. Cavarra, congratulations on behalf of the university, and you did very well. I enjoyed the defense, and I also look forward to your studies, and I enjoyed the discussion. Would have loved to join it, but I was in another position. So before we end this academic ceremony, I have some household things to say to you. So most of the people in the hall may leave as I close the ceremony and wait for us where we have the drinks. The family in the first row may stay with us because we will first make a picture here and say goodbye to our online opponents. Then we move to the hallway for a picture on the stairs, and then we come to all of you to congratulate Mauro, the young doctor, on his degree. So hereby I close this academic ceremony.